learn well today, for what you learn will benefit your patients. Robin and I are not going to totally repeat each other because we come from two different perspectives. In the Division of Drug and Alcohol Program Licensing, we are the State Methadone Authority. The State Methadone Authority is appointed by the governor to exercise responsibility and authority for the governance of opioid dependence. I've been given the title, if you want to call it that, of state coordinator. I would like to introduce Cheryl Williams, who is the director of the Division of Drug and Alcohol Program Licensure and is the State Methadone Authority. As you circulate today, if you've not met her, please introduce yourself. She's going to be taking on a larger role. Okay. What I'm going to try to do is figure this thing out. Talking about, before we start anything, you have to know the legal basis and why you're doing what you're doing, and why the docs just can't write a prescription for methadone out of their office like they do for any other drug, except for the treatment of narcotic addiction. The Controlled Substances Act of 1970 was a federal legislation that requires that an agent used to treat narcotic addiction must be administered, dispensed, ordered via an approved narcotic treatment program. This has to be registered with the Drug Enforcement Administration and follow what's now SAMHSA-CSAT regulations. In addition to the federal regulations, there are state regulations that control and govern the treatment of narcotic addiction using an agent. The DATA Act, or the Drug Addiction Treatment Act of 2000, amended the Controlled Substances Act. And this is the legislation, again federal, that permits office-based physician practice for the use of buprenorphine in the treatment of addiction. And that's on an outpatient basis. There are 3 legal agents that are permitted in the use of the treatment of narcotic addiction. Most tried and true is methadone. LAM was approved for a while. It's still on the books as being approved. It is no longer manufactured due to cardiac problems. And the last were the ones that were introduced as a result of the Drug Addiction Act of 2000, Suboxone and Subutex, which are the trade names for the formularies using buprenorphine. What's going on out there? Yes. This is what the state looked like in 2001. The blue counties represented where the narcotic treatment programs were that were using methadone. If you notice, you go basically from Harrisburg to Pittsburgh, and there was nothing. There's more blank white than there is treatment programs available. This is what it looks like today. So in 7 years, we've gone from 27 programs or facilities to 50 facilities. The growth we're projecting is going to continue, and it would not surprise me if within the next year we added another 10 programs at least. The need is there. The purity of the heroin is there, what's on the streets is there, and Health Choices has made some of this growth possible through having funding available to pay for treatment in the more remote sections of the state where it was not available before. We have, in addition to the number of the 50 narcotic treatment programs, 15 of those are also approved to use buprenorphine in the narcotic treatment program, meaning the physician can choose either buprenorphine or methadone for the treatment of narcotic addiction. This is on the facility DEA registration basis. Most of those that are using the buprenorphine are doing it through a research project and having it funded that way. Those who want to use buprenorphine within the NTP are still having trouble with funding. And I know that's something that Robin is very interested in and has been advocating for. We have 26 residential programs that are approved to use buprenorphine for detoxification. And we have 1 residential program that is approved to use buprenorphine for maintenance. In terms of the growth, we've had the facilities to support the increase in the numbers. If you go back to 2001 and notice Region 3, which is the central part of the state, we had 179 patients. And this is a static count based on the date of the site visits. So it is not a cumulative as what Robin was giving you. In Region 3, there was one program, and that was in Harrisburg. Regions 1 and Region 4 were the two, Philadelphia and Pittsburgh area. Philadelphia was the largest. We go to 2008, look what's happened to the picture. We've gone and increased by almost 7,000 patients any one day in treatment. But we've also now have more programs and more people seeking treatment in the western region of the state than in the southeast, which is a significant change in where treatment providers are located. I gotta watch my time. If you recall, and some of you have been around long enough to do this, back in the 70s and 80s, you're not, and I hate to say typical because there is no such thing as a typical patient. Every individual is unique, but the profile was more of male, Caucasian, in the 35 to 45-year-old range, IV heroin, drug use, probably no other drug use involved, and did not come with the load of baggage and problems that you're seeing now. Today, we're looking at probably 60-40% split male-female. We're looking at a younger population. Instead of being the 35 to 45, we've got more in the 25 to 40-year-old range in treatment. We're looking at polysubstance abuse. They don't come in using just one drug anymore. It is multiple drugs. It's combinations that you and I never thought could be put together. We're looking at not only at IV, but we're also looking at snorting, prescriptions, hillbilly, heroin, and then you throw in a host of concurring mental health disorders. So what you're treating is far different than what was being the patient that was treated 20 years ago. And it requires new skills on the part of the providers and the physicians. Where we have been focusing a lot of our efforts in the past 3 or 4 years has been on pregnant patients. I say we, meaning the division. We've always had, and it's been the cornerstone in Pennsylvania, the Family Center at Thomas Jefferson that has been replicated nationally. But when we went to the western part of the state, there really were no resources for the pregnant patient. We have worked with hospitals in the western part of the state. We're now doing the same thing in the central part of the state, and are encouraging every provider to have specialty groups for pregnant patients. I think almost everybody does at this point. If you're at capacity, we will instantly go one over capacity to treat a pregnant patient. They have the highest priority. That is not changing. I think they said at McGee Hospital in Pittsburgh, they're converting 2 to 3 women a week from street narcotic opiates to methadone, and referring them to 27 different programs. Philadelphia is probably about comparable. So the need, you're having more pregnant people on your caseloads. Another area that we've expanded in terms of special populations is the prison programs. We have an agreement now where if a female pregnant is incarcerated at the State Correctional Institute, they will refer that patient to Cambridge Springs outside of Erie. We have a methadone program there that provides the methadone. Because remember, a doctor can't prescribe for the treatment of narcotic addiction. It has to come from an approved clinic. So they are bringing the methadone to the prison. They bring the inmate to the methadone clinic weekly for counseling and urine analysis. And the system is working. We've got programs that are now, prisons that are permitting facilities, narcotic treatment programs, to go in and for the males, detox them over a period of 2 to 3 weeks instead of going cold turkey. Females that are pregnant, they are now staying on methadone during their pregnancy. Or if they come in and they find out that they are pregnant, they will then allow the conversion. If anybody has questions, there are copies of the protocols, and I'll show you that in a minute where they are located. The last agenda frontier that we have to cross in terms of special populations is just coming up, and that's dealing with co-occurring mental health disorders. And you'll hear a lot today on the use of benzodiazepines and panic attacks and anxiety disorders. But that's probably the biggest challenge facing this field. In terms of future needs, we have an aging of our population. We've been so successful in treating the population that they are not dying from drug use as they did 20 years ago in their 50s and 60s, and they lived to be that long. But they are now successfully being maintained in narcotic treatment programs and getting old and in need of nursing care, in need of personal home care, in need of inpatient in-home services, not able to come to the clinics. And this is going to be the challenge of the next 5 years, because again, the nursing homes cannot write that prescription for methadone. It has to come from a narcotic treatment facility. We've been able to get a couple of nursing homes to agree to do that, but it's been a very arduous uphill road to climb in terms of being able to maintain the patient on methadone while they are in the nursing care. Personal care homes is the same issue. The last one that's going to be facing more and more of us is transportation. As you have both the aging of the population and more rural clinics opening, the access is going to become more difficult, not because of a lack of clinics, but a lack of public transportation, county van systems. I had a woman, they called me, what do I do? She's in a wheelchair, she fell, she has to get down a flight of stairs to get to the program. How do we get her medicated? And that has taken some creative thinking. But what we're saying, and I'm saying, is something like that, call us, we will work with you. Lastly, I leave you with this thought. If you can dream it, you can do it. That's what I feel about this conference. This was something Trudy, Dr. Flaherty, and I started, and I think you're going to learn a lot today. If you have not, on the back table, back there, there's a CD. On the CD, and we put it together specifically for the narcotic treatment programs, are all the regulations specific to narcotic treatment. New, clean copies of all the exception forms for take-homes doses. There are protocols in terms of whether it be a nursing home, prison, pregnant woman. There are also listings of all the current narcotic treatment programs, buprenorphine programs. And there is the exception waiver in here, which Robin mentioned, where the Secretary granted the exception